Good evening, Dits.
Good evening, Faisal. How are you, my friend?
Good, my friend. Good evening, colleagues. We're just waiting for the disclaimer to for us to project the disclaimer and wait for the numbers to pick up. Dits, how's things down in the Eastern Cape?
Absolutely amazing, Faisal. We've been going through what I consider to be about a 10-year drought.
Wow.
And last weekend, it's one that's just passed, we had an almighty storm. It lasted about half an hour, but it gave us 35 millimeters of rain, but we've had quite a lot of soft rain prior to this, so it just ran off. And unfortunately, in our road, where I live, one of the stormwater drains was blocked, and the water instead went down my mother's cottage driveway, built up in front of the garage door, and then broke through. And it was like a waterfall coming down. Anyway, we sorted it out, but yeah, otherwise it's good. When it rains, life's good.
Okay, as the numbers are picking up, I'm just going to do some housekeeping announcements. For those colleagues that are on at the moment, please refrain from using the raised hand, but rather type your comments and questions in the Q&A tab at the bottom of your screen. CPD certificates for this webinar will be available on the SADA platform. If you're not a SADA member, you can still join via the SADA website and access your CPD certificate. Tonight's lecture accounts for 1 CEU point. We are also streaming live on YouTube. So in case any of you get bumped off, the recording is available on YouTube. And please remember the evaluation at the end of the webinar. Dits. So it's been 1 year, my friend. We've had the most amazing...
Glorious year. One glorious year.
We had the most amazing series. It's a bittersweet moment for you and I. There have been a lot of behind the scenes negotiations and haggles, but here we are. We are at the grand finale. So today is the Dentistry's Great Awakening grand finale, as well as the last webinar for the year on the SADA platform. So it's symbolic. I think we've achieved phenomenally this year. We've had close to 5,000 colleagues joining us over the series along the year. We've had phenomenal speakers from 4 or 5 continents. I've made friends, you've made friends. We've all been exposed to a new way of thinking, more lateral thinking, a thinking that exposes us to seeing dentistry more than just teeth and gums. So I think if that objective's been fulfilled, I think we've achieved a lot. But I think we've come a long way, and it's been the most amazing journey this year. You've been the most amazing host, and tonight the host becomes the teacher. So we are looking forward to your years and years of insight, and a lot of questions, hopefully at the end. So I'm going to briefly introduce you, Dits. I know this introduction doesn't do justice to the person that you are, to the experience that you have, but I guess everyone that's got to know you so far this year as a facilitator of the program realizes the insight that you bring. And tonight, the opportunity is for you to link the learnings of the series from webinar 1 right till the last webinar, and tell us what was the intention? What was this all about? Was there a story to tell? Are there pieces of the puzzle? It's left to you to put it all together for us. So without further ado, Dr. Eichhoff is an experienced airway-focused dentist in independent practice in Makanda, is that how it's pronounced? Formerly known as Grahamstown in the Eastern Cape. Over the past 40 years, he's traveled globally extensively, developing networks, fine-tuning his skills, fine-tuning his knowledge, achieving a few postgraduate qualifications in functional orthodontics, early intervention therapy, dental sleep medicine, myofunctional therapy, and obviously diode laser use and capnography. So I'm hoping you can use all of that experience, Ditmar, with what we've achieved this year from all of the speakers, and you've got an hour to really impress us and leave us with something to think about over the holidays, seeing that this is a grand finale. This is the last of the Great Awakening webinar, as well as the last SADA webinar for the year. So Ditmar, without further ado, my friend, I'm looking so forward to this. The floor is yours.
Basil, thank you very much, my friend. What I'm going to do is I'm going to share my screen, and then that's the easiest way to do the introduction. There we go. Let's just find it there. Oh, sorry. There we go. Can everyone see my screen? Faisal? Good. Right.
Oh, good. It looks good from my side. Thank you. You're good to
go?
Thank you.
Thank you very much. Right, colleagues, it's wonderful to be with you. And Faisal, thank you so much for your introduction. Tonight's subject is a very, very complex subject. And an hour, although it'll give me the opportunity to introduce and to link things together, it's by far not enough time for one to really do it justice. So I'm going to go through some basic concepts, and then I'm going to do a couple of case presentations, which in most respects is what we really want to see and what's going to link everything together nicely. So, oh, why isn't it paging on? It's certainly very strange. I'm screen sharing, and but it's not paging on. So this is the final presentation in the Dentistry's Great Awakening series. Thank you those who have attended all the presentations in the series during the course of the year. We trust that you have enjoyed the presentations and that the DGA series has created a platform for you to build on. Thank you to SADA for the opportunity to use their platform. The purpose of the series is to open up our minds as a profession in South Africa to what is already happening and well established abroad, and to enable us to grow and share. The goal of my presentation today is to share my experience of 20 years in dealing with breathing disordered sleep or sleep disordered breathing, face growth guidance, temporomandibular joint disorders, obstructive sleep apnea, and to share information and opinions which I believe represent the most current thinking, clinical experience, research, regarding our role as dentists in the world we live in today. This does not mean we have to abandon what is and has been successful, known from and done in the past. So we're not trashing any treatment modalities. There's no saying that this discipline is wrong or that discipline is wrong. It's a case of the disciplines are growing, new information is coming to the fore, and we as a profession need to keep going and to be on the forefront. I believe we as South Africans, as the South African dental profession, have a lot to offer the world. And this is really where the future lies. So, sleep disordered breathing is a complex subject. My presentation will be kept simple, even though there is substantial information provided. If you wish to read the fine print in this presentation, because there's so much information, this is recorded and available on the SADA website or on YouTube, which should enable you to pause where you wish. I do not represent any persons or company or endorse any products. People, companies, or products mentioned are used for illustrative purposes only, or as an explanation for the purpose of this presentation. All opinions expressed are mine and mine alone. So why should we be interested in sleep disordered breathing or in obstructive sleep apnea, or what I like to call airway focused dentistry? The American Dental Association adopted a policy on dentistry's role in the sleep disordered breathing arena. The ADA says dentists should be screening their patients for sleep apnea and should be the professionals who make oral appliances. So in the rest of the world, there's an acceptance and a recommendation that we as dentists be involved. And I believe we've got a really central role to play. And I hope to clarify this as we go along. So first of all, one's got to consider what is life. There's several definitions, many definitions, in fact, but the one that I tend to like the most is it's the existence of an individual human being or animal. And that's what it's all about. But that existence can be altered and changed for the better or for the worse. And sleep disordered breathing matters, issues, definitely change our existence for the worst. So we really need to be able to help folk that we deal with every day. So, and why is this? Why are sleep and breathing issues so important to us as dentists? Because the mouth is the gateway to human health. So let's investigate this. Consider the human body. Look at it from this perspective. This is the way I look at it, makes it actually easier for me to understand what's happening and to also evaluate and diagnose. The human body is like a house. So we have the human body, the internal organs, the human body on the other side. Now, this house has two entrances, it has two exits, and it has furniture in between. The two entrances, the nose lets in air, and I call that the pedestrian entrance. The mouth lets in air, water, and food. I call that the front door or main entrance. The exits are the urethra, that's our drain, and the anus, which is our garbage outlet. Then in between where the mouth is and where the outlets are, so where the inlets are, the nose and the mouth, there are a whole lot of structures. These are internal organs, and I call those the furniture. And what happens to our furniture is solely dependent on what enters through the nose and what enters through the mouth. And because the nose only lets in air, which we know is critically important, the mouth lets in air, water, and food. So there cannot be any other structure in the human body that is as important, because these organs can only function if air, water, and food is coming in through the mouth on a daily basis. Literally second for second, minute for minute, hour for hour. Good. Now think of that house. It has an electrical system. So do we as human beings. We have a nervous system which consists of a peripheral aspect to it and a central aspect to it. That's the brain and the spinal column. The peripheral aspect or peripheral nervous system embodies autonomic control and also somatic control. And then the autonomic control has a sympathetic and a parasympathetic aspect to it. So does a house. A house has electrical wiring. This house has water pipes and taps. So it has a circulatory system, both arterial and venous, and is very complex, just like a house has an internal water system of pipes and taps, which can be quite complex. It has a waste system, which is the lymphatic system. The house also has a lymphatic system. It has a skeleton. The house has a framework. The house is covered, has walls. Those are the muscles. And then, of course, those are the things that we don't always see, but are actually becoming more and more important now, is fascia. That's the tissue that holds the muscles together and is very important because the tongue is actually connected to the base of the tongue, is actually connected to a fascia. And this fascia runs from the base of the tongue all the way down to your toes. So if you have ankyloglossia, tongue tie, then your fascia is going to distort. And that's where so many of our postural issues can come from. And that's why the tongue and tongue tie is now becoming so important. So that's one of the aspects of the link between the mouth and the rest of the body. And of course, because the tongue is tongue-tied, it can fall back into the airways. That can block the airways, and then you start getting your airway obstructions, and that's how the whole process develops. I'm going to just show you diagrammatically going forward how that happens. So how does a tongue tie affect so many things? Torticollis, crawling, recessed chins, forward head posture, dowager's hump, and scoliosis. The tongue is connected to your entire body. It's like the rudder of the spine. When it's out of alignment, other parts can go off kilter and cause issues which seem unrelated. Then this house also has a ceiling, the maxilla. It has a floor, the mandible. Of particular importance to us, of course, is that part of the mandible which articulates with our skull on both sides bilaterally. That's the temporomandibular joint. Now, this is a very important joint. The reason for it is that it's got a very, very important nerve supply, which means that any problems associated with this temporomandibular joint can manifest in different parts of the head and skull, and not only there, but also obviously in the spine. That's just a closer look at the nerve supply involving the temporomandibular joint. You'll see that the trigeminal ganglion is involved. And then, of course, blood supply. So you can see it's connected to some really very important blood vessels. And if one looks at it even further, you can see those blood vessels, obviously, are the blood vessels that run through the neck. And that's the micro anatomy of the temporomandibular joint. And then, of course, as dentists, we need to see teeth, but in many respects, they are very important. And it becomes clear if one goes into occlusion how important the teeth are. Good. So why is this important for us as dentists? What do teeth, breathing, sleep, and airways have to do with one another? The reason is there is an intimate relationship between orodental, craniofacial development, and airway growth and development. So if one has to really look at this, I consider health to have 9 pillars. This is just the way I think about it. So when I'm evaluating a patient, these are the things I think about. The first one, the most important, is breathing. Because if you stop breathing for 4 to 5 minutes, what happens is you die. But now remember, breathing has 2 aspects to it: the mechanical, the process of muscle action of breathing, and then respiration, which is the exchange of gases, oxygen, carbon dioxide, nitrogen, water vapor, etc. That's known as respiration. And at cellular level, that's critically important, because if your hemoglobin isn't giving off enough oxygen because you're either respiratory acidotic or alkalotic, your mitochondria aren't going to be oxygenated. They're the energy stores of your body, and you won't be you won't be synthesizing ATP, ADP correctly. Right, then the second most important aspect for life is hydration, or drinking liquids, water. If we don't drink liquids for 4 days, then you also die, because most times your kidneys go into failure. And then the third most important, obviously, is nutrition, and that's food, and we're all very familiar with the concept of nutrition. Then comes posture, because that involves the neurological system. In other words, your spine, and if your posture goes out of alignment, all those nerves running off the spine that supply your organs can basically misfire, almost like the leads, spark plug leads of a car. If you kink it, your spark plug doesn't work properly. Then the fifth pillar of life is sleep. Obviously, we have sleep as a very, very, very interesting subject. You have your circadian rhythms, your sleep-wake cycles, REM sleep, non-REM sleep, etc. Then the next important factor is exercise. And in today's world, we either over-exercise or under-exercise. And it doesn't seem to be a balance with many people. Then we start getting into the more unseen aspects of life, and that's intimacy and emotions. If you're not loved, or you don't have emotions about something or someone, it affects your immune system. Spirituality and culture, because they very often determine how we view life and how we view health. And then the last one is human communication. And I feel that, given the experience of the last 2 years, that's the aspect of life which I think is almost the most important. Because if we're breathing, hydrating, and we have nutrition, if we're not communicating as human beings, we die. We die inside, and possibly even physically. Right, but if you look at it, for me, the most important part is sleep. Sleep is in the middle. And of course, breathing, hydration, nutrition, and then posture, exercise, intimacy, emotion, spirituality, and culture and communication affect sleep very dramatically. And vice versa, if there is some form of neurological central nervous system aspect affecting your sleep, it can lead to issues with intimacy and emotions. We think of depression, we think of those types of problems. So there's this intimate relationship between these factors. Good. So if you think about it, if you really think about it, if we go back to the picture of the human body, starting with the mouth and nose, the most important structure that's common to all 9 pillars of health is the mouth, because it lets in air, water, and food. But nature doesn't like us breathing in and out through our mouths, because we give off carbon dioxide when we exhale, and that isn't good for blood pH. Henderson-Hasselbalch equation, it's not good for hemoglobin, because if your pH isn't right, hemoglobin holds onto oxygen, and that affects our whole body, because without oxygen, we know we can't survive for more than 4 minutes. So where does all of this start? It starts with genetics and epigenetics. Now, genetics is a study of hereditary. That's the genes you inherit from your mother and father, and how qualities and characteristics are passed on from one generation to another by means of the genes. That's known as your genotype. Then we have epigenetics. That's the study of how your behaviors and environment can cause changes. Remember, breathing is a behavior. It's established in your first year of life. And if it's dysfunctional, it's imprinted on your brain. And it's very difficult to break that dysfunctional breathing pattern. So that if by your second year, if you have a dysfunctional breathing pattern, your swallowing pattern goes. By the third year, your face is already starting to grow in the wrong way because the airways have been affected. So it's the study of behaviors, environment that can cause changes that affect the way your genes work. Unlike genetic changes, epigenetic changes are reversible and do not change your DNA sequence, but they can change how your body reads a DNA sequence. In other words, epigenetics expresses how you look. In other words, your phenotype. So where does life start? It starts at the moment of conception. But by birth, the process is already well on its way. And Germán Ramirez, Professor Germán Ramirez, has done some wonderful work on just this issue of development pre and from birth. And his book is really well worth reading. So that's where it starts, the embryo, and why it's so important for us is because the pharyngeal arches give rise to, obviously, aspects that involve the mouth and the face. And so there's this intimate link between the airways and obviously facial development. So why, where, and when do things go wrong? It all starts with genetics. You have your epigenetic factors that modify genetics that can lead to obstructive nasal breathing very often, because inflammation is one of the biggest reasons for issues we have with human bodies these days. And if your nose is blocked, and even from the moment of birth, if your nose is blocked, you have a problem. So then that leads to chronic mouth breathing, that leads to imbalanced breathing because of that CO2 buffer, Henderson-Hasselbalch equation. It's a pH buffer system, the most important and the first one. And then we get imbalanced facial development, imbalanced airway development. We get forward head posture because you can't breathe properly. We get body posture imbalances. And that leads to things like disease, sleep orders, respiratory disorders, and obstructive sleep apnea. So you can see how it all fits together, how breathing and the human body are all interrelated, and facial development, the mouth, they're all interrelated. There's an intimate relationship between airway development, facial development, posture, sleep, and overall health. This is just another way of showing it from birth to childhood to adulthood. Genetic factors, environmental factors, they combine to form you can have craniofacial abnormalities, upper airway obstruction, soft tissue effects, and then ultimately obstructive sleep apnea. These soft tissue effects can in turn change the way the upper air or bring about upper airway obstruction, collapse. Soft tissue effects can also obviously change craniofacial structure because we know of Melvin Moss's theory, which we'll be getting to. Right, here's a cause and effect relationship. Frequent respiratory infections, nasal septum deviations, contracted maxillary arch, narrow arch, and ultimately that all leads to craniofacial abnormality and malocclusion. This is just another way of putting it. This is my own diagram. It's quite complex, but it really helps me to understand what I'm dealing with. Right, so what are the results of a mismatch between genes and the environment? Many things: obesity, metabolic syndrome, celiac disease, intestinal permeability, type 2 diabetes, insulin resistance, that's a really big one. Fatty liver disease, infertility, cardiovascular disease is a big one. Hypertension, some cancers, autoimmune diseases, asthma, autism, this is still being debated. Asperger's still being debated. Alzheimer's still being debated. There's no question about ADD, ADHD, in my mind, associated with sleep breathing disorders. Depression, functional somatic syndrome, Parkinson's still being looked at, chronic back pain, definitely, osteoporosis, definitely. These are chronic, non-communicable diseases. Remember, there are 4 diseases in life: bacteria, viruses, fungi, and parasites. Everything else is non-communicable, and it's a non-communicable diseases are as a result of something, not infective. So what do the scientists and the clinicians say? They've been saying for many, 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 many years, here's clinical success in early orthodontic treatment. Why orthodontics? It's not because orthodontics has been blamed for anything, etc., etc. It's just that orthodontics is the discipline that's been involved in correcting malocclusions. But it's essentially been concentrating on teeth, which is fine. There's nothing wrong with that. But it's also got a component that involves the face, the cranium, the spine, and the rest of the body. And that's where the link comes. This book has been written by Guy Perrier de Arc. He's former head department of orthodontics, University of Nice in France. And then Antonio Patti, he's the International Center for the Study of Clinical Orthodontics in Verona, Italy. Why early intervention? Beginning early orthodontic treatment, even dental treatment, doesn't necessarily have to be orthodontic treatment, seems eminently logical because it enables the complete or partial correction of many incipient discrepancies, or at least a reduction in their capacity to grow worse. Interception or early intervention employs simple therapeutic techniques that do not overtax the limited stores of cooperation young patients can bring to the therapeutic encounter. Excuse me, and I'll explain that further on in the presentation. Its objective is eliminating or minimizing dentoalveolar and skeletal disorders that interfere with growth, function, aesthetics, and psychological well-being of children. That's from their book in their preface. Right. Orthodontic treatment, dental treatment, should be in harmony with modern medical thought. It is better to prevent than cure. We should not treat the symptom. We should treat the cause. The therapeutic devices available for this endeavor are not complex, but deciding which ones to use and when to employ them is far from simple. The therapeutic choice is nothing more than the last act in a complete diagnostic process. The ideal age for an initial orthodontic dental visit in the author's view is when the patient is about 5 or 6 years old. Right. Why orthodontic treatment? This is the whole preface. You can go through it yourselves by watching the recording afterwards if you really want to read the fine print. It's basically, I've picked out the 2 most important aspects of this preface. And then they end by saying the earlier treatment begins, the more the face will adapt to your standards. And we should add in airway. And the later treatment begins, the more your standards will have to adapt to the face and the airway. Right, the ideal age is 5 and 6 years old. And the goals of this first examination are to discover any discrepancies that would worsen in time, any transverse, vertical, sagittal interferences that are disrupting normal growth, and any functional matrices that are disturbed by mouth breathing, atypical swallowing, and postural problems, as well as destructive habits, such as thumb and lip sucking. There are 3 types of treatment that can be adapted to meet the clinical needs of each patient. Modification of functional behavior without appliances through myofunctional therapy, breathing retraining, or occlusal equilibration, or all 3. The second is orthopedic treatment of the maxilla or mandible. We think of Schwartz appliances, we think of ALFs, quad helixes. There are many appliances. And then the third is treatment with a simple removable or fixed orthodontic appliance. Okay, treatments will be followed eventually by retention and re-evaluation after eruption of the permanent dentition is completed. Has the intervention completely resolved the problem, or will a second phase of treatment be needed to finish aligning the teeth? Now, I work very much with a second phase of treatment. That doesn't mean every patient is treated that way. It just depends on how it presents. It's so important to ask questions of why and when things have happened, and then determine your treatment accordingly. The objective of early treatment is to avoid or to simplify treatment of the permanent dentition. You'll see, I'll show you some cases. This volume addresses the different anomalies according to the angle classification and with regard to their stage of development in either the primary or mixed dentition. Right, so my journey started with when I read van der Klaauw, who first proposed and was later supported by Melvin Moss, who expanded on the concept of the functional matrix. What is that? So what is the functional matrix hypothesis? Essentially, it's defined as the origin, form, position, growth, and maintenance of all skeletal tissues and organs is always secondary, compensatory, mechanically obligatory, necessary response to chronologically, that's age-related, and morphologically, that's characteristics, prior events or processes that occur in specifically related non-skeletal tissues or organs or functioning spaces. In other words, bones do not grow, bones are grown. If we look at it a little differently, it proposes that the origin, development, and maintenance of all skeletal units are secondary, compensatory, and mechanically obligatory responses to temporally and operationally prior demands of related functional matrices. Bones do not grow, but are grown, thus stressing the ontogenetic primacy of function over form. This is in contrast to the current conventional scientific wisdom that says it's genetic rather than epigenetic that controls such growth. So if one looks at this, you can see an intimate relationship between soft tissues and the bone structure. Spine over there, it just stands to reason. There we are. Bones react to spaces. Bones also react to muscles. Just 500 years ago, caries, malocclusion, and sleep apnea were rare. This was discovered by, or who expanded on it, Professor Robert Corricini, by working on skulls and comparing skulls from about 400 years ago to modern skulls. He found that the human face has undergone more change in these last 400 years than in the, according to him, the previous known history of humankind. And he was a research fellow, Human Biology Council fellow. He felt so strongly about it, in fact, that he wrote a book, How Anthropology Instructs the Orthodontic Diagnostics and Malocclusions and Diagnosis of Malocclusions Causes. Right, there's a very good book to read by Dan Lieberman, also an excellent read, fascinating read. And then, of course, we have Professor John Mew with his tropic premise. He says, because the genetic control of skeletal growth is not precise, the articulation of the teeth and jaws depends upon additional guidance from oral posture, tongue against the roof of the mouth, lips together, breathing through your nose. Weston Price realized how important nutrition is. He traveled the world. He looked at primitive tribes, and he found that because being on traditional diets, they were free of decay, they had strong bodies, resistance to disease, they had fine characters, beautiful straight teeth. And his conclusion is malocclusion is a product of the diet of industrialized societies, and that the industrial diet is mostly sugar. It's a single environment trigger. It's a single environmental trigger that could result in a wide spectrum of diseases. Starts with periodontal disease, tooth decay, it can be obesity, diabetes, hypertension, and when it involves airway problems, it's just so much worse. These are also good books to read. Epigenetic Orthodontics by Professor Dave Singh, brilliant read. Straight Talk about Crooked Teeth by Ken Lawson, Cause and Cure of Malocclusion by John Liu. Right, now we get to, for me, what was the most significant of all the reading I did is The Essentials of Facial Growth by Hans and Endler. They're two biologists. They weren't doctors, medical doctors or dentists, and they just studied facial growth and development. And they're saying, and they found, if what they said in their book was, if there develops any regional childhood variation along the course of the airway that significantly alters its configuration or size, growth then proceeds along a different course, leading to a variation in overall facial assembly that may exceed the bounds of normal pattern. The airway functions in a real sense as a keystone to the face. That is so powerful. The oral jaw musculature is responsible for the vital positional relationships that maintain the oral pharyngeal airway. The oral jaw musculature, which includes the neck. The axial musculature around the vertebrae is also involved. These primitive neonatal protective mechanisms protecting the airway provide the motor background upon which, with growth, all the postural mechanisms of the head and neck region are developed. Physiological maintenance of the airways is of vital continuing importance from the first day throughout life. And it's the one aspect of what we do that we are ideally placed that we just haven't looked at. Mouth breathing is considered as dysfunctional breathing, and it results in altered genic signals from the functional matrix, muscles, and the tongue, and the genic tissues then work towards a different balance combination, producing a variation in facial morphology. In other words, mouth breathing, which constitutes dysfunctional breathing, results in the development of or aggravates jaw imbalances, cranial distortions, establishes malocclusions, and negatively affects normal growth and development of children, and affects the systemic health and well-being of adults. Virtually everything once presumed to be reasons why clinicians must work with growth were obsolete perceptions that existed before there was a working understanding of craniofacial development. This is what Hans and Endler said. That's orthodontics. And it's not knocking orthodontics. That's dentistry as a clinical discipline is markedly out of date. And I do not see a groundswell of interest throughout orthodontics that we should do, or dentistry, that we should do what badly needs to be done. As he said, this greatly saddens me, and I do not understand it. This is Zarush Zagi, airway thinking. Just as airway thinking is changing dentistry, it is changing medicine as well. Enlightened physicians have to reconsider their focus on symptomatic treatments and address root cause etiology. Okay, so Zarush Zagi is a Harvard Medical School, UCLA head and neck surgery, Stanford University sleep surgery. He is an ENT, Los Angeles, California, and is affiliated with multiple hospitals in the area, including Stanford Hospital and Clinics, UCLA Medical Center of Santa Monica. He received his medical degree from Harvard Medical School and has been in practice between 6 and 10 years now. And the Breathe, what's his website called? The Breathe Institute. It's just fantastic. Right, and then our good friend, Dr. Professor Steve Almos. This is an excellent piece to read, and he says that there's rather read it. It's just too long. It's just going to waste too much time for us. And then some more there, which is basically just supporting what I've been speaking about from the beginning. Right, then you get the Harvolt experiments on oral respiration, and these experiments showed that the monkeys adapted to nasal obstruction in different ways. like human beings would. In general, the experimental animals maintained an open mouth. Some increased the oral airway rhythmically, while others maintained the mandible in a lower position with or without protruding tongue. All experimental animals gradually acquired a facial appearance and dental occlusion different from those of the control animals. And what was so interesting about this is that it wasn't predictable malocclusion. It could be a class 1 with crowding, could be a class 2, it was a class 3. There was no common abnormality that developed. Right, so sleep disordered breathing, what is it? It's a general term for breathing difficulties occurring during sleep. It can range from frequent loud snoring to obstructive sleep apnea, a condition involving repeated episodes of partial or complete blockage of the airway during sleep. It is a potentially serious disorder. Risk factors include age and obesity. It is more common in men. It includes symptoms such as loud snoring, feeling tired even after a full night's sleep. And treatment often includes lifestyle changes such as weight loss and the use of breathing assistance at night, such as continuous positive airway pressure. But it also involves dental appliances and also a focus on facial development and airway development. Okay, the American Medical Association differentiates between certain types and subtypes of sleep-related disorders. Obviously, obstructive sleep apnea, then sleep-related hyperventilation disorders. They involve blood levels of carbon dioxide during sleep that result from a lack of air moving in and out of the lungs. It's often tied to other health problems. A specific type of sleep-related hyperventilation disorder is obesity hyperventilation syndrome. Then we get the sleep respiratory hypoxemia, and that is a low level of oxygen in the blood. Sleep-related hypoxemia disorder is when oxygen concentrations drop, but the levels of carbon dioxide don't rise high enough to cross the threshold for diagnosis as a sleep-related hyperventilation disorder. And then we get snoring, and that's just air moving in and out, generally around the floppy tissue at the back of the throat. As many as 27% of children, 40% of adult women, and 57% of adult men snore. When it occurs more than 3 nights per week, is classified as a sleep-related breathing disorder. It may be referred to as primary chronic or habitual snoring and is differentiated from frequent snoring associated with obstructive sleep apnea. But what's important here are the oxygen saturation levels. And then we also get cataphrenia. There's a pattern of abnormal breathing and vocalization that is often referred to as sleep-related groaning. Right, this is the spectrum of sleep-related breathing disorders, from snoring to obstructive sleep apnea. This is no disease like normal breathing, occasional snoring, regular snoring. And then we get obstructive sleep apnea, which is part of a disease paradigm. Upper airway resistance syndrome, mild sleep apnea, moderate and severe sleep apnea. Okay, then pediatric sleep disordered breathing is a general term for breathing difficulties during sleep. Can range from frequent loud snoring to obstructive sleep apnea. When a child's breathing is disrupted during sleep, the body thinks the child is choking. Heart rate increases, blood pressure rises, the brain is aroused, and sleep is disrupted. Oxygen levels can also drop. Right. Obstructive sleep apnea occurs in infants and children, although considerably less often than in adults, up to 1 to 5% of all ages. Right, potential symptoms and consequences of untreated pediatric sleep disordered breathing may include snoring, irritability, bedwetting, learning difficulties, ADD, ADHD, concentration difficulties, slow growth, cardiovascular difficulties, obesity. The spectrum of pediatric sleep disorders. Some of these are prevalent in children and adults. Some are prevalent in children. Some are more prevalent in children than adults. And then there are those that are unique to children. Right. 30% of adults is more common. OSA may affect 30% of adults and is more common in men than women. We know that. And it's a condition that is likely highly underdiagnosed. And what's important here, and that's important for us as dentists, is people with obstructive sleep apnea might not be aware of their interrupted sleep. Many people with this type of sleep apnea don't realize they haven't slept well at night. Right, symptoms amongst adults can be excessive daytime sleepiness, loud snoring, observed episodes of stopped breathing during sleep, abrupt awakenings accompanied by gasping or choking, awakening with a dry mouth or sore throat, morning headache, difficulty concentrating during the day, mood changes such as depression or irritability, high blood pressure, decreased libido. Sorry, everybody, my internet connection seems to have dropped. Right, we'll just have to find our spot again. Sorry about that. I hope you can all still hear me. There we go. Let's just find it quickly. The only problem we have with this erratic internet of ours. So there we go. Health implications. Right, so the health implications of sleep disordered breathing and obstructive apnea. They can be increased resistance to airflow through the upper airway, heavy snoring, marked reduction in airflow, frank apneas with or without. Faisal, can you hear me?
Yeah, we can't see your screen.
Oh, okay, that's strange because I can. I'll just go to resume screen. Can you see anything now?
Yeah, now you can screen. Now you can do presenter view.
Okay, let's go to, yep. I just want to find where I was. Health implications. Now, you should be able to see it now.
Yeah, we see it, but it's not the presenter view.
Okay, well, on my screen, it's got the full screen. So I can keep going on presenter view unless you can just advise me how to change to presenter view.
On the top, you see slideshow. Can you go into slideshow?
Okay, I must just, let me see. Resume, let's go to slideshow. Now, where is slideshow? There it is. I seem to have, there's a funny bar across my screen.
Hi, sorry, Dr. Dittmar.
Yeah.
Can I ask you just to stop the presentation, stop the sharing of the screen. When you then rejoin, make sure that you've selected there's two blocks that you need to select. Please select those two. then start the presentation again, it should allow you to then, for us to see it in presenter view.
Okay, so I'm going to exit completely.
Let's try just where you are now. Let's just try to share again. If not, then you need to
Okay.
take a minute, log out, and then log in again.
Okay, I'm going to do that. Okay, what are you seeing now?
We are seeing it as before you do the slide mode. So let's try slideshow.
Okay. Just as a matter of interest, Sepal, at the top of my screen, there's a whole bar that's got mute stop video. It's on the top of my screen and it's hiding some of my information. How can I get rid of that?
Just quickly, please log out and then use the link again to rejoin. There are two columns that you need to select. Select those two. It'll allow you to then, it will take away that block completely and allow you to then continue the presentation.
So I'm going to leave completely.
Please do. Thank you. We do apologize to everybody. Just a moment to rejoin.
Right, I'm back in again. Can you hear me, Sepal?
Yes, Doc, I can hear you. Okay,
Okay.
let's just try presentation again. I'm also just trying to do something from my end.
Because I can share screen. So I'm sharing the screen now.
So Doc, if you just close this window and we go back to your desktop.
Close this window and go back to my desktop.
Yes, please.
Okay, I've done that.
Okay. I think your presentation is there at the top there.
Yes,
Final
it is.
draft. Yes, please, if you can open that, please.
There we go. Let's see. Can you see that now?
I can see that. And then if we find let's go straight from this screen. Let's go straight to slideshow and see.
I can't see. I've got that funny bar at the top that's not allowing me to go to slideshow because it's covering it. I'll go to the slideshow.
Okay.
That's the presenter view.
Okay, just yeah. Okay, there we go. There we go, Doc. And then
Are
we
we
can
back
start.
again?
We're back again. I'll just sort it out from my side. Thank you.
Wonderful. Let me just go back to where I was. There we are. Sorry about that, everyone. Gosh. It can be so darn disruptive. So we've got the idea that there's an intimate relationship between facial growth, malocclusions, and airway development. And that's the reason why we as dentists have such an important role to play in the area of sleep medicine. Right, health implications, there we go. So it affects the respiratory system, it affects the endocrine system, especially, this is the one important one, is insulin resistance, type 2 diabetes. Of course, you have the interplay between leptin and ghrelin. Leptin suppresses your appetite, ghrelin excites your appetite, and if you're not getting enough sleep, your ghrelin levels jump dramatically, and that's why people nosh. Good. Then your digestive system, it affects your digestive system. It can cause heartburn, gastroesophageal reflux disease. Then it's circulatory and cardiovascular system, blood pressure, heart attacks, strokes. Heart failure is also more common in people with sleep apnea, atrial fibrillation, abnormal heart rhythms, your increased risk of stroke. It's your nervous system. And of course, because there's one type of sleep apnea called central sleep apnea. So you get sleep apnea, which is obstructive, central, or mixed. And then it can affect your reproductive system, reduce your libido. So this is how I like to view it. In the center, we have physiology. And then on the one side, we have structure and function. And on the other, habits, behavior, psychology, neurology, pathology, disease, and medications. Those change our physiology. But when it comes to physiology, the way we deal with it mainly in our society, Western medicine, is we tend to treat symptoms with medication and or we combine with surgery. What we preferably need to do is look at structure and function and habits and behaviors as dentists, because that's the area that we can fulfill the most the most expertly, if one could call it that. So, right, how do things come about? How do we develop obstructive sleep apnea or airway obstruction? Infiltration of pharyngeal tissue, that's deposition of material in the upper airway structures like obesity, Cushing syndrome, Prader-Willi syndrome, mucopolysaccharides. Then 2, enlarged tongue, soft palate and uvula, Down syndrome, hypothyroidism, acromegaly. This is a very nice summary for you. Then thirdly, mucosal edema and inflammation, especially of the nose and the pharynx, caused by snoring, allergies, or upper respiratory infections, which may narrow the upper airway. Enlarged tonsils and adenoids. We know there's a lot that's said about that in children. Anatomical malformation of the jaws, like in genetic Crouzon's, treated Collins syndrome, Pierre-Robin's syndrome, cranial base abnormalities, Chiari formation, achondroplasia, Klippel-Feil syndrome, then pharyngeal dilator weakness, muscle weakness, myotonic dystrophy, muscular dystrophies, medullary lesions, motor neuron disease, structural lesions like tumors of the pharynx, attached treenae, tongue tie, buccal ties, and then surgical correction of cleft palate, then incoordinated breathing such as Drager syndrome and dysostomias, and then trauma, birth trauma, especially forceps delivery. Then the reasons for obstructed airways can be developmental, thumb sucking, arm sucking, object sucking, and not being able to breastfeed properly because you can't latch on because you can't breathe through your nose. So the site of the occlusion varies. It may be at the level of the velopharynx, the oropharynx, hypopharynx, epiglottis, or larynx. It may be at more than one level. And that's why it's so important to be able to understand why you have a blocked airway, or at different sites during different stages of sleep, owing to differential activity of muscles involved in maintenance of airway patency. Any disorder that produces or contributes to upper airway narrowing could cause obstructive sleep. Obesity is the most common associated sign. They're often seen early in life. That's why it's so important for us to be involved. But do not attract attention before the occurrence of socially disturbing snoring, daytime tiredness, or disrupted. Right, then we just look at adult versus child. We have to view them differently. Children, especially with mouth breathing, they'll have generally an underdeveloped upper jaw and one that is not big enough for all the teeth, and the adult teeth erupt, that they will be crooked. So let's go to cases. This is a 55-year-old gentleman who came to see me. He was referred to me by a colleague, in fact, and he'd been for a sleep study, and they'd found that he had obstructive sleep apnea, but my colleague just didn't feel comfortable dealing with this particular patient. And you'll see why. You can see that massive lower jaw, that massive tongue. You can see the splaying of those upper teeth. And you can, this is just a different view. That's the tongue. You can see how that tongue is just pushed everything aside. Now, what was interesting is that his wife said that he hadn't been like this before. And that's when I viewed this case, when something triggered in my brain. Because if you look at his nasal breathing, I use rhinometry. You can see that represents the inferior nasal turbinate, the middle and the superior nasal turbinate. Those are the average, that's the normal breathing slope, if one could call it that, with an increase in the nasal valve area. Then there's very often in that inferior nasal turbinate airflow area passage, there's almost always a drop in volume, and then it picks up nicely to the middle and superior. There's nothing wrong with his nose. But when we looked at his pharyngeal airway, and I use pharyngometry. Now, pharyngometry, it's important, doesn't diagnose obstructive apnea, but it's a very, very useful screening, non-invasive screening tool to check for airway volume and to check for airway collapse. So don't let anyone tell you that pharyngometry is not useful. It's not diagnostic. It's a good screening tool. And I could, for instance, tell by looking at this green line, that's where the mouth starts at naught and goes down to the epiglottis down there, that his mean airway volume is 1.61 centimeters squared. Okay, for a Caucasian male, it usually should be around about 3.2. So he had a very, very constricted pharyngeal airway. And if you look at it, it's at the back here, at about 5 centimeters back or so in that area. That's where the posterior wall of the pharynx, the palatal drape, uvula, and the back of the tongue meet. So with that massive big tongue, etc., there had to be obstruction there. And then if we put him to a stress test for breathing, his airway volume collapsed, and it collapsed down to 1.13 centimeters square. Now, in his case, that represented 49% of his airway that was left. We need to see a minimum of 70%. So that's why I used, so I could tell from what his wife told me and from looking at the nasal airways volume and looking at pharyngeal airway volume, something started making me think there's something not right here. Then I tested his end-tidal volume CO2, and we can see he was verging on the brink of severe underbreathing, hyperventilation, and his breathing rate was very high, etc. So there was, again, his breathing was dysfunctional. He was upper chest breathing. Okay, so I referred him back to the sleep clinic, and I asked the sleep specialist to please, he has obstructive sleep apnea, but I'm concerned that that's not the real problem, and asked them just to do a blood panel. And what they came up with is they found that his growth hormone was something like 10 times that of a developing child. The gentleman had acromegaly. So you've got to be very careful. If you want to treat that guy orthodontically or with an appliance, you're going to kill him. There's just no question about it. Right, this is a youngster who came to me, stunted growth at the age of about 12, 13. You can see by his eyes, the venous pooling, very dull eyes, crusting around the nose, dry lower lip, crusting around the mouth. This young man hadn't been to school for a year. His mum had been to just about every doctor and specialist they could find in the country, and no one knew what to do with him, until eventually one pediatrician said, honestly, we don't know what to do with your son. We don't know what's wrong with him. Well, if you look at his mouth, you'll see massively underdeveloped maxilla, okay? Large developing jaw. This man is a class 3, developing lethal class 3. You can see very high palatal vault, no space for his canines, etc., etc. Lower arch, crowding of the lower incisors because that mandible's growing, but it's trapped against this underdeveloped maxilla. And we treated him. Started treating him with an ALF. So if we look at the date, that was the 8th of December, 2008. By the 8th of February, March, April, May 2009. This is what he looked like. Okay, he hadn't yet recovered, but totally different boy. He was back at school. He had friends. He could play sport, etc. Okay, that's 2009. That's what it looked like a year later, approximately a year later, with an ALF. Lower canines and premolars coming through, space developing for those canines. You can see, just a look at the maxilla, how the whole palatal transverse volume is, width is improved, etc., etc. Canine coming through, canine just about to come through. That's what he looked like on the 30th of April, 2010. Completely different boy. He was growing at a rapid rate because he hadn't been growing for 12, 13 years, stunted growth because of oxygen deprivation. That's what his occlusion looked like. You can see he's still got a bit of crustic, but it's getting better. And that's almost 2 years later. That's the lower arch. That was in 2015. What happened was we developed to a certain point, and then I let nature take over. And this is what nature presented us in 2017. And he was as happy as a lark. He didn't want any further treatment. He was breathing. He played provincial cricket. Everything in his whole life had just changed. And you could see that potential class 3, how we've developed, well, mainly dentoalveolar, but the point is, does it really matter? Because this man has improved dramatically. This is what he looked like in 2015 when he came to see me. And that's how he had grown from a stunted growth within the space of a couple of short years. That was his plan when we started off. You can see the impacted canines over there. Things looked a bit better in the mandible because it was obviously class 3. And that's what he looked like in 2015 when I saw him to follow up. Completely different boy. Just a completely different boy altogether. That was his starting pan, and this was the Bimler Elite analysis. Clearly showed us a class 3 with an upper jaw that was set back by -2.5, which is fine for males. Don't always necessarily have to use reverse pull headgear to bring it forward. And the length of his maxilla was good. It's a little undersized. We want to see a factor here of 5. That's where one divides the size of the lower jaw into the anterior cranial base and the upper jaw into the anterior base. You get a factorized figure, and for the maxilla, that's generally about 5. And you can see from this constricted airway. So it confirmed what I found with the pharyngometry and rhinometry, etc. Right, this is another interesting young case. This is, I've got his permission to show his face. That's why I didn't block out his eyes. He's the son of one of my staff members. We saw him in 2009, and you can see this is what he looked like. Look at those bloodshot eyes. This young man wasn't sleeping at all. The venous pooling. Look at that facial development. And if we look at the dentition, that's what he looked like. This had come about because of serial extractions. A dentist had removed certain primary teeth, and unfortunately from there on it was just downhill. That's how he presented. Very high palate, narrow palate, big tongue, etc. Now that was 18th of March 2009. The 2nd of November 2010, that's where I developed him to with an ALF appliance. So a marked improvement, and we can see that the canines are now starting to show signs of coming through on the upper right-hand side as well. It's not by any long means perfect, but we were getting there. We were getting there. And then in 2015, that's the point to which he got, and he decided that's where he wanted to stay. He didn't want to do any further development or treatment until last year, and that's when we put him into braces, and that's where he is now. This was on the 8th of the 12th, which was yesterday. So you can see where we've come from, where we started non-extraction, using just an ALF appliance, doing controlled rest, and when the patient was ready, we moved on. And that's the situation. Look at that wonderful maxilla transverse width. Look at those 7s tucking in. It's just 2 different people. That's when we started the pan. That's the Ceph. Again, this showed a class 2, a good maxilla and good maxillary length, position and length. The mandible, we had a factor of 10.5. We like to see 11 there. So he's got a small mandible, which in many respects with a class 2 is not necessarily a good thing. But because we developed forward, we always developed forward, we were able to achieve what we did. This is an interesting case of a lady in her mid-50s, and she was referred to me by a colleague. She wasn't sleeping at all. She was anxious. She had headaches, daytime sleepiness. She'd have to sleep sitting upright, etc., etc. And if you have a look, you can see that maxilla is compromised, and the bite is compromised. We can see the attrition, the mandible is trapped, etc. Just to show you, and that's what her bite was like, and that was her original pan, and this was the original Ceph. It's a class 2, well, it's a class 1, but we have a maxilla that's positioned very, very far back. Okay, very far back, and that obviously occludes the airways. We can see this massive long palatal drape and uvula. These days now, I actually diode laser those with a special laser called the Snore laser by Alexion. And so her maxilla was set back very far, but she didn't want reverse pull headgear. The position of the size of her maxilla was short. There we want a factor of 5, and then the mandible, the diagonal length of the mandible was also small, should be 11. So in a way that helped us. You can see this is the 3 rendering of her pharyngometry. You can see that's her baseline breathing, that's her collapse breathing. So what we did was we started treating. We treated with upper and lower ALFs, and we opened up these spaces over here. I'll show you more. And she got to the point where all her symptoms just totally disappeared. She did an overnight sleep study, no obstructive sleep apnea. That's where we developed her to, those spaces. There's a bit of an overjet. What she decided was she didn't want any more treatment. She was living a good life. She could sleep. She wasn't tired. She had no headaches, no temporomandibular joint clicks, and she was happy to leave it just there. Right, this is another case of a youngster. You can see the very deep bite, the very narrow maxilla, posterior cross bites, etc. Trapped mandible, crowding. That's the right side. That's the left side. That's seen just looking almost up towards the nose, just to show you the deep bite, the very narrow palate and the high palatal vault, the lower arch, which is not too bad, but also a slight space shortage. That's what her pan revealed, the original pan, and that was her Ceph. And we can see the fact that she has this long palatal drape, and that's resting on the back of her tongue, and her tongue comes around here. The hyoid bone's not too low, but it's lower than we would like it to be. Her Bimler elite showed that she was developing a class 3. Again, her maxilla, very, very far setback. For a female, no more than 1 degree or 1.5 degrees setback. And then obviously it was also very short at 4.3, factorized at 4.3. So the maxilla is where the problem lies. And then the mandible was actually long relative to the anterior cranial base. This Bimler elite analysis is just so easy to use. So that was kind of when we evaluated her, 16th of January 2017, and then we treated until 2020. We treated for a year, and then we let things rest a little bit. I call that a controlled rest. And then I used what's called a Spall appliance, a Spall split vertical, where you have a flat plane just behind the upper incisors, and you have a lower ALF type of appliance, and it brings the mandible forward, and then you close the occlusion simply by using those elastics. And that's how it's an easy way to, you can see the anterior bite, flat anterior bite plane over there. Over there is a better view of it. That's the lower ALF that we're using, and it was designed in such a way that when you applied elastics, those premolars and molars didn't roll lingually. Here we go. And that's what she looked like when we started off. Cross bites, posterior cross bites, very narrow arches, etc., etc. That's when I first saw her. That's the panorex when we started off. That's her ceph. You can see the open mouth posture, the very long uvula and palatal drape again. That's her Bimler elite. Sorry, I didn't get the name out there. But good maxilla. The length is good, and the mandible is a bit short. And we took her to a certain point with our treatment, and then we treated her with clear aligners. That's a good tip. If you ever find that your lateral teeth don't want to come down, that often happens with clear aligners. You use a sling technique with a button, and you cut little slots at the back in the aligner, and you just string an elastic. You can see the elastic over there, strung around to the back, and that just brings it down incredibly quickly. Good, and that's today, 9th of the 12th, 2021. We took her clear aligners off, took her buttons off, etc. That's where she is now. Nice broad arch, still palatal volti, lower arch is good. She does have a bit of scalloping of the lateral borders of her tongue, so obviously one would like to have seen a smaller tongue situation, and that's her ceph for today. And we can see lip posture is different. It's a situation that's just 1,000 times better. She has no problems. She also had fatigue, all of those issues that we find with these patients. And this is another case, again, patient with bilateral posterior cross bites, active freedom. Now, what's very interesting is watch that freedom. We did nothing to that freedom other than just treat her with an ALF appliance. That was her starting ceph, and this is the Bimler elite. Also maxilla that's a very fast set back. We have a short maxilla and the mandible that's also small and short. Okay, this is 19th of the 11th, 2021. This is where we've got her to now, and I'm busy now going to finish this case with nothing else other than just a myofunctional appliance, because you can see her issues are myofunctional. If we really have to, depending on what the myofunctional appliance allows us to do or gives us, we might just do a session, a period of clear aligners just to finish off the dentition. So we're starting to end off. When we look at our situation as human beings today, we function on 3 levels: health, sickness, and death. Very few of us ever attain the level of health. Most of us lie at this level here, and it's sick, not sick. Sick means you have symptoms, you go and you get medication or you have surgery done. Very often, most times, what happens is you go from sick to death. Okay, modern technology, medical technology is able to pick you up from near death back to sickness, but very seldom do we go back to health. So we as dentists must try and work on, not for only our patients, but for ourselves as well. We need to lift ourselves from being chronically unhealthy to being healthy folk. What is health? That's also a very good question. Good. So here we are. This is what can happen when you have airway related problems. And then the interrelationship here, it's time to put the mouth back on the healthcare map. And we have the medical discipline, we have dental discipline, and in between we have mouth and airway. And that represents narrow jaws, tongue tie, crowded teeth, teeth grinding, snoring, TMJ, etc. So medical symptoms and dental troubles. And the impaired mouth eventually harms the brain. Oxygen deficiency, poor sleep and diet factors, and then obstructed airway from impaired mouth issues. So we have a very, very important role to play. So if you practice dental sleep medicine, or as I call it, airway dentistry, you need to know that your patient is in the right mental space. You need to look at physiological status, biochemistry, meds, lab tests, PSG, overnight sleep screening for obstructive sleep apnea. You need to look at the physical side of things, the facial analysis, craniofacial status, dental status, oral status, occlusal status, TMJ status, airway status, and x-rays. Treating these issues is like removing the layers of an onion. Okay, and the process that we all need to follow is first recognize the signs and symptoms that there could be breathing disordered sleep. Communicate that with your patient. Then you do screening. That can be questionnaires, that can be rhinometry and pharyngometry, that can be watch pat. Then you evaluate everything, and then you set a diagnosis. Once you have a diagnosis, you'll either consult with a medical or other dental colleagues or other healthcare providers, and you'll either refer and treat, or refer or treat. So that's in a nutshell what we should be doing. Right, if we just look at another way of looking at it, functional assessment, you check for obstructive sleep apnea, airflow, upper airway resistance syndrome, and this is just the flow diagram for adults as to how you will evaluate them. That's just a little more in depth. That's a little more in depth as well. Watch the video and you'll be able to go through the finer detail. So in summary, we need to look at whole health. And all dentists, healthcare professionals, etc., can help patients restore, maintain whole health, whole body health by acting upon certain truths. All parts of the body are connected to one another and to nature's laws. The whole is made up of all physical, emotional, fluid, and energetic systems to support healthy functions in life. Each part contributes to the whole, while the whole supports each part. The mouth is a pivotal part of the whole that can either build or block natural health. An impaired mouth handicaps the whole body's ability to run itself, which has whole body consequences. An holistic mouth is the start of whole body health, and a wide open airway from a well-developed craniofacial skeleton is a necessary part of an overall wellness program. Right. So the future of dentistry is bright, exciting, and challenging. However, if we want to participate in the bright future, we shall need to take charge and embrace change. We need to take a deep breath and view current dentistry from a different perspective, which involves the entire human body, the whole. We need a paradigm shift in our thinking, in the way we treat our patients. What we do need right now is open minds for change, to build on what has already been achieved in the past. Dentists presently have a valuable role in achieving greater levels of understanding and experience to benefit our patients and to set the platform for future generational colleagues. How can we achieve this? Through education and by sharing with colleagues and cooperating with one another. Right, so this is just what is a paradigm shift. For many years, the practice of dentistry has been focused on dental health, the care and repair of teeth and supporting structures for teeth. This has been labeled quite correctly the tooth paradigm. Dental specialities, the odontics, such as prosthodontics, endodontics, periodontics, orthodontics, were created to focus on parts of this dental universe. Teeth, their internal and external structures, and how they occluded was, and for the most part, is still the focus worldwide of dental education and practice. And that really does need to change. Professor Amos said so. Dr. Neil Langer said so. So paradigm shift is defined as an important change that happens when the usual way of thinking or doing something is replaced by a new and different way. There is a transformational and fundamental change in the way of thinking and behaving. This change is driven by new information and societal needs. Paradigm shifts are characterized by periods of denial, ridicule, attack, all the things we've experienced, then growing belief, and finally acceptance. And I really do hope the Dentistry's Great Awakening series has allowed the growing belief and final acceptance. We need to create beautiful smiles, balanced faces, better breathing, and blissful sleep. Education is the key. We need to educate ourselves and we need to educate our patients. Thank you very much. I really enjoyed the series and I enjoyed tonight's presentation. We actually need years of education for us to really get to understand. And that's all in your own personal hands. Good. Thank you, Faisal. Right, let's get to the really interesting part now, which is the questions.
Just before we get to the questions, I just got to tell you that was amazing. Thank you for that. Your nurturing way of teaching resonates and comes through. And I love how you ended off with a paradigm shift, because the Great Awakening series was definitely a paradigm shift. All the speakers in the world have attested to it. All those from 5 continents that have been on the series, they've congratulated SADA and the South African dentists for an initiative that no one else in the world has done. So there's no doubt that what's been achieved this year with this 10-part series that's never happened before is without a doubt a paradigm shift. And the hope is that we can build on this as a profession and take this a profession more laterally, make it more than teeth and gums and make it whole body focused, where dentistry plays the core role in whole body health. That's the intention. We're hoping that we can obviously build on this platform going forward. With that being said, Dids, the questions are pouring in. So,
oh dear.
so let's get to them. The first, so I'll go through each question and let's just have brief answers, because there's a lot of questions that we've got to go through, right?
I'll try my best. I'm not known for my brevity, but
Dr. Lance Vedetsky wants to know, what's the optimal age to treat a tongue tie, and is there any other way? Is there any other way to cut it other than a laser? And can a tongue tie reestablish itself?
Yes, this is very interesting, and that's still under debate and very controversial. There is no ideal time. It depends on the signs and symptoms that you associated with each patient. So it might be soon after birth. It could be at the age of 6. It could be at the age of 20. It all depends what it's associated with. And then also remember, a tongue tie doesn't always have to be treated. It's always your patient's decision or the parent's decision. Can you only treat it with a laser? No, not at all. Dr. Zarush Zagi treats both with scalpel and with laser, but he always sutures. So if you are going to use a laser, then remember it's ideal to suture, but you need to understand how far you can go with releasing a tongue tie, because you get an anterior and posterior tongue tie, and often those merge, and sometimes you have to go further than just dissecting or bisecting the little frenum. So what happens very often is, if it's not done effectively, you get scarring, and or you can actually, it's not really regrowth, it's more scarring than anything else. And that's the value of Sarah Hornsby's orofunctional myology therapy. When you treat tongue tie, you need to be able to, you exercise that tongue to get those tissues flexible. So you do that before the surgery and you do it after the surgery. So I hope that helps to answer that question.
Yeah, we were lucky to have Sarah as our third speaker on the series. So if the colleagues can go back to that lecture, should give you more insight. Okay, Anonymous asks, it's a bit of a long question comment. Do you think the effects of modernity, starting with induced childbirth in a hospital setting, abandonment of breastfeeding, a refined high-carb diet that is devoid of mastication, bad posture, lack of sleep, and artificially induced immunity all lead to the inevitable destiny of crooked teeth, malocclusion, STB, and OSA for all children born today? Our children have become sitting ducks for all the time to come for this malady. There is no turning back. Do you have a hunter-gatherer's guide for the 21st century? Yes, I don't think it's a question, but what I can tell Anonymous is that he or she has basically summarized this 10-part series aptly in what they've just commented. This is basically it. This is it. This is spot on. This is what's come of it. And this is what we need to try and change with dentistry. So for Anonymous who posted that, I think this was probably the most highlighted comment of the series, because that's the point.
It's very interesting. There's a picture that you find on the internet that shows how man's evolved from being on all fours to being upright. And what's happening now with modern culture is, because of the computers and the fact that we're sitting at our desks all day long, we've gone back to almost being on all fours again. And that's our challenge. That's our challenge. And we can play the best role possible. We can't do everything, or we can't treat everybody, but we can certainly help those within our sphere of influence. And but you can only do so if you're educated. I stress that you need to be educated. It's not something you can undertake just as a sideline. It's actually the focus of what I do every day of my life. I have other folk doing the other aspects of dentistry. So it has to become something that almost becomes what you do every single day of your life.
So another anonymous question. I find that pacifiers from birth can only benefit a person as it encourages nose breathing from a young age. Is this the right view, or does a pacifier encourage destructive habits?
Mm-hmm. Well, the general consensus out there is that pacifiers aren't good, because they prevent the tongue from going up into the palate. But what's far more important is that you shouldn't be substituting a pacifier for breastfeeding. The action of breastfeeding is critically important, because breastfeeding with the latch on extends that nipple right down to the back to the soft palate, and then the tongue presses up against that to express the milk. And it's that expression of milk and that volume of tissue in the maxilla that brings about its development. And of course, it has to be in balance with breathing, because if your epiglottal lock, if you don't have an epiglottal lock, or that's not functioning well, what happens is that you have a blocked nose, you tend to suck in air through your mouth while you are breastfeeding. And of course, that can have other consequences, gastrointestinal consequences. So pacifiers, we use pacifiers for our children, but really as an emergency measure more than anything else. And the moment very often it was just to fall asleep, and when they'd fallen asleep, we just took the pacifier out. I certainly wouldn't use a pacifier all the time, nor would I use soft foods when they start eating. And of course, try and avoid a spoon too, if you can. Get them onto more substantial food choices. There was a very good presentation given by Jill at the Total Health Conference in 2019. You may remember. It's worth going back on that.
But also to add on breastfeeding, the whole breastfeeding mechanism stimulates the masticatory function. And if form follows function, that function is what develops craniofacial growth and development ultimately. So that's really the importance of breastfeeding. So spot on, and thank you for that, Tets. Okay, the next question. What is your personal opinion on the influence on children of this entire COVID episode for the last 2 years, including the vaccinations, on everything you have spoken about? What do you think Weston Price would have said, or what Daniel Lieberman that you quoted is saying about in the past 2 years? But
You know,
this is probably the
that's a
vaccinate,
really
not vaccinate debate. It's not something for us to get into, but I think
it's a
Western science
real
is turning its
curveball.
grave.
Yeah, for me, the whole aspect of it has been that children have suffered psychologically and emotionally more than anything else. The 2-year period in which we've had these lockdowns, etc., are probably not not extensive enough to have really brought about any major changes in facial growth and airway development in children. Obviously, if children aren't exercising properly, they aren't sleeping properly because of psychological problems, etc. Of course, that's going to have effect on the human body. I don't think so much on facial growth and airway development, but more on the hormonal system, on the respiratory system, the gastric system, and psychological and emotional well-being. I think that particular aspect with depression and anxiety has been the worst part of this whole COVID pandemic. When it comes to vaccines, there's so much controversy out there. It's not for me to comment. I know what my preference is. For me, that's personal. And I would rather have science evolve and hopefully give us more clarity on what's going to happen going forward with the virus.
Thanks. The next question is up your alley. Can you briefly touch on the connection between dysfunctional breathing and bruxism, and are the two related?
Well, interestingly enough, bruxism is a medical movement disorder. It's classified as a medical movement disorder. And it has always been associated with psychological issues, stress, anxiety, depression, etc. But one needs to look beyond that. And it's now very well documented, very well documented. If you go onto the internet and you research airway, breathing, temporomandibular joints, and bruxism, you'll find millions of references that there is an intimate link between dysfunctional breathing. Oh my goodness, I've lost you there. Dysfunctional breathing, facial development, etc.
Is there an idiot's guide in the form of formal lectures, books, webinars that one can use to learn about sleep medicine? Where does one start? Your guidance would be most appreciated.
Yeah, that is always obviously a very big question. And when I started literally 40 years ago, but really started in earnest about 20 years ago, there wasn't really anything available. The only avenue I could pursue was that of John Flutter with the myofunctional appliances, and I visited him in Australia. I've traveled extensively abroad in the search of knowledge and experience. And then I did Dr. Skip Truitt's entire orthodontic orthopedic course, temporomandibular joints, etc., etc. That formed the foundation of my knowledge. And from there, and at about that stage, from about 2007, it started coming to the fore. There are now really, really good courses you can attend. And one of them I can recommend, no question, is Professor or Dr. Steve Almos's course, because his courses embody everything that I've spoken about. And he is completely comfortable with orofacial myology, the use of lasers, etc., etc. What I'll do, Faisal, is I'll put together a list of websites and I'll send them to you or Sada, and then Sada can just post them out to the guys who would be interested. Those would be my recommended colleagues to start with. But it's not an easy road, fellows. It's not an easy road. It needs dedication and commitment. There's just no question about it.
I think also it might be worth mentioning that Dr. Davi Schlibush is instrumental in SADSMA, and that could also be an avenue of getting involved. And from my discussions with Davi, they should get some traction in the new year. So that could also complement all the resources that you're talking about. Eh?
Yeah, just as an interesting point though, Faisal, is that it's now getting to the point where you have to do Alison Bentley's course to be able to be accredited. And in future, because medical aids are now starting to recognize the need for the treatment of obstructive sleep apnea by dentists and dental sleep medicine, and they're now making codes and payments available, but they won't unless you're accredited, and the only way to do that is through Alison Bentley. So I'll keep you updated. You're probably on the same forum, and so we'll keep folk updated, and it's worth undertaking that even as a good start.
So I think we'll keep the finger on the pulse, and whatever initiatives they are going forward, SADA will probably communicate it with the industry. So we'll leave it to SADA to do.
Absolutely.
Okay, the last question is, are there Hpcsa restrictions on the involvement of dentists in sleep medicine? From what I understand, there's no restrictions from the mandibular advancement devices perspective, but obviously sleep medicine falls in the realm of the sleep physicians, and we're meant to complement what the sleep physicians do and not obviously compete or challenge them. So I think there's no clear guidelines. I think we have to wait for guidelines in the coming months, but definitely where we can get involved is on airway development, is on breathing disorders, is on treating mouth breathing, and complement our skills with the sleep physicians. But we'll leave that for SADA to also, if you can add to it, that'll be wonderful. If not, I think we leave it to SADA to advise.
Yes, I think there are two issues here. The first one is that we're not allowed to diagnose obstructive sleep apnea. Okay, we can recognize, communicate, evaluate, but we can't diagnose. And that is the whole situation with the South African Sleep Medicine Society, with Alison Bentley, is that WatchPat is used. Alison does the diagnosis. If there is a diagnosis of obstructive sleep apnea, the patient has to be informed that severe obstructive sleep apnea is treated with CPAP. If a patient refuses, etc., or can't tolerate it, then we can come in. So it depends whether you're treating children or you're treating adults. When it comes to children, the airway issues with early intervention, that is in the realm of dentistry. And obviously, there we can diagnose in conjunction with our medical and other healthcare providers. So ENTs become important, sleep physicians become important, pediatricians are important. Those are the specialities that I work with all the time. So yeah, the restrictions are at this stage, we can't diagnose, and you can't treat people with severe obstructive sleep apnea with CPAP. And it must generally be a multidisciplinary treatment protocol.
Wonderful.
But I await the guidelines from Hpcsa. SADA has got guidelines. I can provide you with that document if you wanted, but I'm not aware of the Hpcsa ones at this stage.
Okay. Thank you so much, my friend. At this point, I'd like to take the opportunity of obviously thanking all the speakers that made themselves available throughout this year, every month for the webinar series. I'd like to thank you personally for carrying the weight of hosting the speakers and going through the question and answers. And I mean, it's been a fun year. It's been a hectic year. I mean, it's been a year of mixed emotions. So Ditz, I can't thank you enough. You've become like a father figure to me this year. And if anything, I appreciate that the most. I'd like to thank SADA management, in particular the CEO, for his vision and foresight in allowing a webinar of this caliber and of this magnitude to take place on the SADA platform, something that's never happened before. All the stars behind the scenes, Marlies van der Linde, Dr. Ntabiseng Metsing, who was the head of clinical at SADA, Shepo Moletsane, Norma, all of these people that the membership don't get to see, but all of the inputs to make this type of an initiative a success. I really thank each of them from the bottom of my heart. It's really something amazing that we've pulled off. And I mean, it really means a lot. And the feedback we've been getting throughout the year from the profession, from our colleagues, have been exceptional. So definitely it's a paradigm shift. And I think we've lit the spark, and I think others need to now carry it forward. And it's kind of changed our profession to be more inclusive, for us to collaborate more with our medical colleagues, and for us to bring dentistry back into the center of healthcare. My belief is that dentistry is probably the most important profession in healthcare, and in my lifetime, I'd like to see it recognized that way. So really, for everyone that participated, thank you so much. For all the delegates that have joined us every month for the last 10 months, really, we are so humbled and grateful. Thank you so much. Without your guys' support and without your awesome feedback, none of this is possible. Is there anything that you want to say as we close?
Yes, thank you, Faisal. Just to thank you and to thank Sada. We've developed a wonderful friendship, and it's really been appreciated. I'm getting to the point in my career where I'm so-called close to retirement. There's some days that I feel invigorated and other days that I really feel tired. But all I can say is we have a wonderful cohort of young dental professionals in this country. And my advice is, colleagues, let's grow. Let's grow our knowledge, but let's grow together. Thank you. Thank you, Faisal.
Yeah. As we're chatting, there are messages of support coming through on the chat. So it's really humbling. Honestly, it's really an emotional moment, and I'm sure for you as well, right? But really, I think we're onto something, and I look forward to really a bright future in the profession. So guys, with that being said, and with a heavy heart, I officially call the Dentistry's Great Awakening series closed for 2021. Thank you all for all your support. Enjoy your holidays, keep safe, keep well, and let's hope 2022 is definitely a much better year for us. Keep us all in your thoughts and prayers, but more importantly, keep safe. We all need to keep safe so we can achieve the bright future that we see and that we yearn for. So without further ado, thank you so much, and hope to see you guys back in the new year. Thank you.
Take care all.
Don't forget to fill in the evaluation at the end of